చేయాలా? ఓకే.
Please start, sir. Yeah, hi. Good evening, doctors, for attending today's scientific meeting. Today, our eminent speakers and Dr. Moderator sir will be driving this scientific session. With immense pleasure, I would like to introduce today's moderator, Dr. G.V. Prasad sir. Dr. G.V. Prasad sir completed his MD ophthalmology from AIMS Delhi in 1989. His senior most retinologist and ophthalmologist he worked across various places till 2020 and retired from Regional Eye Hospital, Government Hospital as Chief Retina Consultant, Visakhapatnam, and started the next journey as a Chief Ophthalmologist at Medicover Hospital, Visakhapatnam till 2025. Now, sir established his own hospital as GV Prasad Eye Hospital at Madhurwada, Visakhapatnam, and serving with a patient-centric motto, catering all ophthalmic services at this hospital. So, with this, I would like to welcome Dr. GV Prasad, sir, and take the session forward. Sir, please start, sir. Sir, you are muted, sir. Please unmute it. Unmute, sir.
Just 1 minute. Okay. Okay. Okay, Srinivas.
I
Hello.
think two. Yes, sir. Yes, sir. Yes, sir.
Yes. So, good evening, all of you.
I
So,
think two devices are logged in, sir, at your place. Can you please log out one thing?
sound. Okay. Now, is it okay? Only one
No, sir. Still resound is good.
sound is there. Log out. Okay. Now is it okay? Okay. Now, is it okay now?
It's fine, sir. It's
Hello.
fine, sir.
Okay.
It's
Now,
fine,
is
sir.
it okay now?
It's fine, sir.
Okay.
Please go.
So okay. This is okay. Right. Okay. Good evening, all of you, friends who land on Srinivas and Bear Company for organizing this wonderful webinar. So, which is very important topic. Now, after introduction of anti-VEGF drugs in ophthalmology, there is a tremendous changes. Entire retinal treatment has changed a lot. So it has changed the landscape of treatment of retina. So in this context, I would there are so many anti-VEGF drugs are available now, like bevacizumab, starting from Paginax, now bevacizumab, then ranibizumab, and then aflibercept has come. Now with the latest high dose aflibercept is coming to the market, and other drugs are also available with various effects, and there are various types of actions. So all these drugs, whatever treatment we advise to the patient, ultimately we have to increase the duration of the treatment. So in between drugs, and efficacy also is we have to take into factor, because otherwise it will be a burden to the patient. So we should not burden the patient, and it should be effective. That's what our interest is. So in this context, we will discuss all these things, all molecular biology by Dr. Lohit, and effect of aflibercept in PCV by Velagala Aditya Reddy. So first speaker will be Aditya Reddy. Welcome him. So he did his MBBS and MS ophthalmology and fellowship in veterinary surgery and ROP at Amrita Institute of Medical Sciences, Kochi. and currently is working as consultant veterinary surgeon and ROP specialist at Geta Hospital, Tanuku, and he is working as assistant professor at Ashram Medical College, Eluru, and he has various publications on his name and part of various clinical trials as well. And Lohit, he did his MD from All India Institute of Medical Sciences. Now he is HOD of Retina in Visakha Hospital, Visakhapatnam. So he's a very good friend of mine, and he's a junior and he's doing a lot of good work. So he will speak on molecular biology of various anti-VEGF drugs.
Sorry, sir. Sir, there is a two device login from your end. Hello. Hello. Sir, can you please unmute yourself?
Tech support, let it be. Sir, introduction is done.
Okay, sir. But sir is on mute. I am sending the request for the unmuting, not responding, sir.
I'll inform, sir.
Okay.
You don't please inform.
Unmute. So Dr. Aditya, please go ahead.
Aditya, sir, please start your presentation, sir.
Aditya, please start your presentation.
Am I audible?
Yeah, you're audible. Okay, right.
Good evening, all. Yeah, I'm Dr. Aditya. Thanks for the very warm introduction. And I'll be sharing my screenshot. Is my screen visible?
Aditya, sir, please share your screen.
Okay, sure. Okay.
No issue, sir. Take your time.
Is my screen visible?
Yes, sir.
Okay. Yeah.
Please continue, sir.
Good evening, one and all. Today we'll be discussing on evaluating anti-VEGF drugs and its molecular characteristics and their impact on the treatment success. So here is a disclaimer, and there is another disclaimer here. The data, values, and comments included in the slide deck have been sourced from FDA review document, and we also encourage you to review the document for any further insights. Coming to the physiology, in diabetes, we know there is impaired vascular function and impaired retinal blood flow. Then there will be hypoxia, which results in release of molecules like VEGF and the placental growth factor. So now coming to placental growth factor, it is a member of the VEGF family of and it also binds to VEGF R1, and it has higher binding capacity than that of VEGF A. And here VEGF will bind to VEGFR receptor 1 and receptor 2, thereby leading to neovascularization. And placental growth factor will result in increase in the inflammatory cytokines, as well as it will also bind to VEGFR1, leading to neovascularization and ultimately causes vessel leakage and edema. Now here, aflibercept, ILIA is a recombinant fusion protein, and it consists of portion of human VEGF receptors 1 and 2. The domains are fused to the Fc portion of human IgG1. So the main function is it is working as a decoy for multiple targets like VEGF-A, VEGF-B, and placental growth factor, and also galactin-1. So here what it is doing is whenever it is binding, whatever the inflammation that is resulting from VEGF-A and P, placental growth factors, so all this it will bring down the inflammation, neovascularization, thereby bringing down the retinal vascular leakage and edema. So what are the molecular factors that we use to determine how the drug is interacting within the body? If you'll see how well it is, what is the binding affinity the drug is having, and how long is it lasting in the eye, and how potent is the drug, and the target of the drug, and will the amount of the drug affect the outcome? So coming to the binding affinity. So what is binding affinity is how strongly the drug is interacting with the ligands, and it is the key determinant of biological activity. Now, if you see,
చెప్పండి చెప్పండి
am I audible?
Sir, you're audible, sir. You're audible. Sorry.
Something, okay. So now it demonstrates, so here if you will see, the KD value, the dissociation constant, if you see the lower KD means it is having high binding affinity. So this data is taken from Schubert et al., where aflibercept was found to have statistically higher VEGF binding affinity than that of compared to ranibizumab and brolucizumab. And so this is the study from which we have obtained this data. This is a in vivo study. Yeah. Coming to the second factor, that is inhibitory concentration. So inhibitory concentration is a baseline where we measure the potency of the drug. So here, if you are having lower inhibitory concentration, that means it is having more potency. It is nothing but, in simpler terms, the minimum concentration of the drug that is required to produce a desired effect. Now, if you see the amount of drug ranibizumab required to produce a desired effect is relatively more than that of the amount of drug where aflibercept is needed. So aflibercept is more potent compared to brolucizumab and ranibizumab. And coming to the half-life, aflibercept is having a half-life of up to 11 days than when compared to brolucizumab, ranibizumab, and faricimab, which is more compared to this. That means the drug will be staying for the more time, and its effect will be for a longer duration. So coming to how many targets is this drug going to bind? If you know, brolucizumab and ranibizumab are only single target options where they will be binding to VEGF-A, whereas faricimab is having dual action where both VEGF as well as Ang2. It is a dual target mechanism. Whereas aflibercept is having multiple target mechanism where it is binding to VEGF-A, placental growth factor, VEGF-B, and also galactin-1. So coming to aflibercept, when you take the concentration of the VEGF levels in aqueous humor of a patient, these values after when we treated with aflibercept At 1 month, if you are seeing the VEGF levels are coming down, not just the VEGF levels, but also placental growth factor. Because this placental growth factor in turn again leads to um, angiogenesis and all. So it brings down both the PAGF levels as well as VEGF concentration in the intraocular level. So coming to the pathway, the mechanism. So you know that angiogenic factors play a major role in the development of edema, the vascular stability, inflammation, neovascular and vessel stabilization. Here, if you see in this animation, the whenever when there is activation of VEGF R1 and VEGF R2, I mean receptors, it can result in vascular leakage and inflammation. And placental growth factor is also binding to the receptors, leading to the edema and inflammation. Now, when VEGF increases, that leads to rise in Ang2. So that normally Ang1, whenever it is binding to Tie2 receptor, it stabilizes the blood vessel. Now, when Ang2 is binding, what it will do is it will destabilize the blood vessel and it causes new vessel formation. So during angiogenesis, Ang2 is upregulated and that competitively binds the Tie2. In high VEGF states, Ang2 antagonist activity will promote destabilization of blood vessels, and whereas in the low VEGF states induced by anti-VEGF treatment, this Ang2 value comes down. And aflibercept is the most potent binder of VEGF compared to that of any the other available agent. We know faricimab is having a dual target where it binds to VEGF, also Ang2. But recently, they have found one more drug, nesfacimab, which is having even stronger binding affinity for Ang2 than for the Tie receptor. So here, then later on, this study was they have conducted a study where they have divided the groups into navacizumab 3 milligram, which is a potent Ang2 binder, with 2 milligram of aflibercept. And the other group consisted of 6 milligram with 2 milligram, and they termed it as high dose. And the third group is monotherapy, which is aflibercept monotherapy. And these two studies are Onyx and Ruby. Onyx is for neovascular AMD, and Ruby is for diabetic macular edema. And by the end of 36-week period, what they found is all the three groups had similar results amongst them. So combination of nesvacumab provided no additional functional benefits when compared to aflibercept monotherapy. So this is Ruby, where they had 302 eyes, and Onyx they had 365 eyes. So in Yosemite, Rhine, Tenia, and Lucerne studies also, the letter gain when compared, uh, it is no, when compared with the other drug faricimab, the vision gains with faricimab were non-inferior to those of aflibercept at the primary endpoint. But recently, there were FDA challenges on the 8-week interval and 12-week interval data provided by faricimab, and so currently they were questioning the results, but the standard so far the standard is aflibercept then compared to faricimab. So coming to Avenue clinical study, where ranibizumab and faricimab achieved similar levels of plasma Ang2 inhibition after one injection, at the end of week 4, the faricimab failed to meet the primary endpoint of superiority to ranibizumab for best corrected visual acuity gain at week 36. The level of Ang2 inhibition was similar between these agents. suggesting that anti-Ang2 mechanism of action of faricimab may provide no additional benefit over anti-VEGF monotherapy. So just with ranibizumab itself, we are achieving the similar result. So here, through immunoassays, the human VEGF was completely if you'll see this slide, here we are having the levels of VEGF, Ang2 levels in vitreous, in the vitreous, where of the rabbits where human VEGF was completely suppressed after VEGF treatment. At 28 days, if you'll see, with aflibercept, the amount of Ang2 is far less compared to that of brolucizumab and ranibizumab, and which is similar at 56 days. Now, anti-VEGF prevents the VEGF-driven Ang2 production. So at the beginning, there might be both VEGF as well as Ang2, but once we give anti-VEGF, and as the VEGF level comes down, so the Ang2 level, or whatever the Ang2 level is there, that will also be reduced. So this effect is greater and persists longer with VEGF, with aflibercept, as compared to brolucizumab, ranibizumab. And these results of the study support the hypothesis that Ang2 may be expressed secondary to our primary insults to retinal vasculature by the VEGF. So aflibercept finally delivers a comprehensive and highly durable targeting when it actually matters. So the latest guidelines recommended anti-VEGF as a first line to treat DME. And previously, laser treatment has been shown to be an effective treatment option in the management of DME, and pioneering studies compared to sham treatment. But now in current era, anti-VEGF is the major treatment. Corticosteroids are also important in our armamentarium of drugs for treating DME patients, but mostly a second choice. Intravitreal injection of anti-VEGF agents are the first line of treatment in naive DME cases, previously where we used to use laser. Now, because if you see ranibizumab and then aflibercept in diabetic macular edema cases, the number of injections that are required to treat the diabetic macular edema, when compared to aflibercept, the burden on the patient relatively comes down with aflibercept than compared to ranibizumab. As we can space the injections, the duration will be extended. Now here, from the data from the Moore fields on neovascular AMD shows that the vision gains are maintained through year 4 with treat and extend regimen, and the number of injections were averaged up to 7.72 in the first year, and it has come down to 4.67 in the second year. And coming to Morimoto study on PCV, the average number of polypoidal lesions per patient was 2.43 before the treatment, and post treatment 55% of these lesions were regressed completely just after the loading doses. And later on, these patients where the lesions have come down completely required very less number of injections compared to the others. And similarly, in the from the Moorfields data in DME, there was very good visual outcomes, and the reduction in the foveal thickness was significant by the end of 3 years, and vision gains were achieved with a meaningful reduction in the treatment burden. And by the end of third year, the average number of injections that were required were only 2.6. So with this, the burden has come down very significantly. So aflibercept targets where it actually matters, that is VEGF and placental growth factor, thereby inhibiting downstream signaling via VEGF receptor 1 and 2. which is the master regulator for pathological angiogenesis. To date, both preclinical and clinical data suggest that there is no additional benefit to targeting alternatives to VEGF-R signaling pathways like Ang2. So, separate independent studies suggest evolipuzet has a greater binding affinity for VEGF-A, a greater potency, and a longer half-life than others available anti-VEGF agents. These factors contribute to the strong VEGF suppression seen with aflibercept. Thank you.
Aditya, for extensive coverage of all the anti-VEGF and and modern anti-VEGF also, and we will discuss whatever questions are there at the end. So I will invite Dr. Lohit to speak on his topic. So biological, what is his topic? He has to speak on the evolving role of aflibercept in PCV. So some parts are already covered by Aditya, but I request Dr. Lohit to be like enlighten us more about on PCV. Okay, because there are so many drugs, so many latest drugs also we spoke, but we'll at the end we will come to some conclusion which anti-VEGF to start with and what are the preferences of anti-VEGF by you and Aditya. We'll ask some questions. So Lohit is working as a HOD at the Retina Department of Visakhapatnam Hospital, Vizag, and he did his MD and post and fellowship in Retina at RP Center, All India Institute of Medical Sciences, and is a very good friend of mine. And he will speak on uh, his topic is like on PCV, aflibercept on PCV, role of aflibercept on PCV, evaluating VEGF and molecular characteristics. ఇది ఆదిచ్చేది అయిపోయింది కదా evolving role of aflibercept in PCV, APVRS insights and comparison with other anti-VEGF drugs. Please, Lohit.
Good evening, everyone. I'm Dr. Lohit from Visakhapatnam Hospital. Thank you, GV sir, for a kind introduction. Today, I'm discuss about the aflibercept role in the PCV and its reflection regarding the AMD disease also. How it is subgroup of AMD, how the effect of the aflibercept in AMD also. And meanwhile, we will compare the aflibercept with faricimab in the coming slides. So today we will talking about the role of aflibercept in PCV with the APVRS, Asia-specific Vitreoretinal Society insights and comparisons with anti-VEGF agents, especially with faricimab. Skipping the disclaimers, and now we are can see the APVRS guidelines update 2025. With the PCV diagnosis with HD-OCT or SS-OCT as a major criteria, if we see the sub-RP ring-like lesion and first complex, we will initiate the treatment with anti-VEGF monotherapy or combination therapy. But to confirm diagnosis, we need ICG angiography. So after anti-VEGF monotherapy, we will monitor the response with OCT or ICGA. We will see the complete regression and or stabilized SRR. And we will treat accordingly by gradually extending the intervals with the treatment extended regimen. Or if there is a persistent or recurrence activity, we can shorten intervals or we can combine with the anti-VEGF with PDT. In case of large submacular hemorrhage, pneumatic displacement with or without vitrectomy, and if it is an extrafoveal lesion, we can have a laser ablation also. So in the crux of the guidelines, if monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. To date, there are no data exploring whether faricimab or brolucimab monotherapy are superior to combination therapy in patients with PCV. As we discussed by the Dr. Aditya regarding the pharmacokinetics, I'm skipping the slide. In 2016, there were two trials data was there pulled up. The main change in the BCVA at 2 years data, week 96 are compared. In View 2 trial, patients with PCV and patients with neovascular AMD achieved similar vision gains with monotherapy alone with aflibercept. While in PLANET study, PDT was reserved as a rescue therapy for cerebral patients. Coming to the PLANET study, it is a prospective sham control study. It is a multicentric double-masked randomized trial. Initially, 3 doses of aflibercept were given and then randomized to 2 arms again. In the one arm, with aflibercept alone, and the other arm, aflibercept with active PDT. Their endpoint of the both arms are week 52 and change in the BCVA and safety outcomes were measured. And one arm is aflibercept at a 1 month interval, other arm is 1 month interval aflibercept with active PDT. The study point was 2 years week 96. In PLANET study, visual gains are maintained with aflibercept monotherapy with optional treatment extension dosing in 2 years. So in BCVA change in both first year and second year were 8.1 and 4.6 respectively. While in the PLANET study, patients with extended intervals have a better visual gains with reduced treatment burden. In this study, in the monotherapy and rescue PDT, we can see both arms. In the year 2, optional aflibercept treatment extension with 1-2 weekly intervals adjustments are measured. In monotherapy is around wean BCVA change was 10.5, while with aflibercept and rescue PDT was 11.5 in the 2 years data, and mean number of injections were 3.9 in monotherapy, 4.2 in aflibercept with rescue PDT. Both are compared. Coming to the another study, Altair study, where visual gains are maintained with the aflibercept with PC group and non-PC group, that is AMD. So in these two groups, in the year 1, the mean BCVA change was 7.1 in the 1 and year 2 was 3.4 in PC group, while in non-PC group is similar to 7.2 and 3.7. And similar proportion of patients were compared with both groups by week 96. If we see the standard deviation of last treatment interval, it is 12.1 weeks in PC group and 12.2 in non-PC group. Again, it is similar. So another RCT, Margot et al., which they have used aflibercept 2 mg regardless of anemia type. In that group also, in PCV group, they have taken another 2 groups, PCV subgroup and typical AMD subgroup. Mean number of injections in the PC group was 7, while in the first year, in the second year 5. And if you see the typical AMD group, 7.8 and 6.5. If you see both are comparable, statistically significant with reduced treatment burden. Now coming to the real world data. In the RCTs, there are 2 RCTs in the Japanese data we have seen now. Hosokawa M et al. 2017 and Morrison Hosokawa M et al. 2018. In the both studies, BCVA change was 66.5, 65.5. At 3 months interval, they have given injection 59.5%, while at 16-week intervals is 47.3 in second year. Complete progression rate have been seen in the real world series with different studies we can see here with aflibercept. Different data is given, complete progression, but they have taken the different criteria in polyp-regression. That's why we can see multiple variations, but almost similar between the 65 average. And coming to the another study regarding the faricimab, more than 50% of patients were assigned to faricimab with Q20-week dosage intervals at 44 and 48. The mean injections were more than compared to the first year, it is more than 12 weeks and it is 87.5%. In Q interval 12 weeks is 83.4%. So there is a comparative study between the aflibercept and faricimab study. The PLANET study in aflibercept is multicenter double mask randomized. While it is in Salvin, it is multicenter but open label, not a double mask study. And they have 2 arms in PLANET study, where we discussed in aflibercept monotherapy and aflibercept rescue plus PDT. While it is a single arm only, they have in this study they have taken 3 monthly monthly doses for 3 It is 4 months for loading doses monthly once. The endpoint was non-inferiority of aflibercept monotherapy versus aflibercept rescue therapy for BCVA change from baseline to 52 weeks. Mean change in the BCVA in faricimab group is average 40 to 48 weeks. The polyp assessment was similarly both in same absence of polyps and absence of leaking polyps at 52 with ICG group, while in the faricimab also similar with but baseline, but ICG and OCT was used to grade the polyp regression or inactivation. So after with the data of Hera et al., a Japanese trial, aflibercept faricimab, patient PCV cases have significantly better visual outcomes with aflibercept monotherapy alone. We can see the BCVA significantly improved only in aflibercept group at 3 months interval after first treatment, and numerical greater with aflibercept in proportion of eyes with residual exudative change and eyes with complete resolution of polyp. The conclusion of HARA trial was head-to-head comparison real-world study in treatment-naive AMD cases. All patients of course, the Japanese population, both aflibercept and faricimab treatments are effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity after lowering doses. Both intravitreal aflibercept and intravitreal faricimab are effective in reducing exudation and retinal thickness was the conclusion. But intravitreal aflibercept was more likely to eliminate exudative changes and improve visual acuity in short onset. I am showing some of the clinical cases which we have treated with aflibercept. We can see in the picture there is a large PED, hemorrhagic PED. We can see after 3 injections of aflibercept, the patient improved significantly both functional and endocrine outcome. It is a second case, again the case of submacular hemorrhage with thumb-like polyp, double-layered sign here with subretinal fluid with hemorrhagic fluid. After 3 doses, again patient improved to 69 vision, both significant endocrine outcome. And it is another third case. While we are showing these submacular hemorrhages, we are using these nowadays. We use if it is submacular hemorrhage, we use the injection anti-VEGF apart from the gas injection. Sometimes we do vitrectomy, but with the anti-VEGF alone, monotherapy alone, also we can see some cases with complete regeneration of heme and subretinal fluid with good anatomical and visual outcome. So I conclude by saying the aflibercept 2 mg and safety program has been established across cities and supported by a decade of real-world monitoring. More than 20,000 patients from different 20 countries were treated. Greater than 13 million patient years of exposure, approved in total of 7 indications in BRVO, CRVO, DME, myopathic CMM, neovascular AMD, and more than 1 decade, 10 years of RCTs and real-world experience. About more than 90 million doses were sold. Low rates of selective adverse events, rate of intraocular infections are 1 in 1,000 units, 10,000 units. Rate of endophthalmitis is 0.6 in 10,000 units of the units sold. No, and data suggested that no association with the immunologic response. Thank you.
Okay, thank you, Lohit and Dr. Aditya. Wonderful presentation in a short spell, very good presentations. So I want to ask a few questions because which are relevant to the ophthalmologist. Now I want to ask Aditya first. What is your first line anti-VEGF? Suppose a patient of diabetic macular edema or with the patient with CNVM. What is your first line drug?
So in diabetic macular edema, usually my first line of anti-VEGF is ranibizumab. But if it is neovascular AMD, I mean CNVM, my first line is Eylea. I mean aflibercept. Aflibercept, I will give an option to the patient, and based on the financial status of the patient and all, my treatment goes.
Okay.
So my
First,
first line of
you
choice is
prefer
alprazolam.
Eylea in CMVM.
Yes,
And for diabetics, you prefer
prefer ranibizumab.
Okay. What about Lohit? Lohit.
Sir, with the previous patient support program, aflibercept I use in both DMEs and CMEs. So after when the price control has been made, now we are shifting to the only PCV cases and MD cases and select to DME cases. First line is definitely aflibercept as it has low adverse events reported also. So I use aflibercept as a monotherapy and most of the cases.
What about financial burden to the patient?
We explain, especially when the patient, we explain regarding the effectivity because it lasts for a minimum of 6 weeks duration. So after let me explain the number of injections and the duration of action, uh, duration of the treatment also. If we calculate the per year, it will be number of injections will be less and effectivity is more. And even in cases of patient is not systemically stable also, we can give the aflibercept. So after the counseling, it will be easy, especially more affordable patients.
Okay, you follow PRN regime or treat and extend?
Depends, sir. If it is an uncontrolled diabetes, I give the doses of 3 loading doses, treat and extend. But in cases when especially PC cases, some cases will resolve in 1 or 2 doses, then we will stop and extend also.
So generally, what is Aditya? What about you? You
Sir,
follow
for every
PRN or this one?
for
Treat
every
and extend?
patient, my first and foremost thing, I will tell the patient. So whatever might happen, if you are willing for the treatment, you need to get 3 loading doses.
Okay.
Only after 3 loading doses, I will start. And my OCTs, I will observe the OCTs, and when and where the visual acuity comes down and the thickness increases, I treat.
Oh. So when do you switch to other anti-VEGF? Suppose if you start on this thing, when do you plan to switch?
So initially, when the patient is responding to a drug, and after 3 doses or 4 doses, suddenly there won't be any reduction in the height of the PED or, in the PCV cases. So in such cases, I have shifted to the other molecules like brolucizumab and faricimab. And again, once the activity is reduced, for the next injection, there are cases where I have come back to aflibercept and it worked well.
Okay. So ఇందులో పెట్టు అందులో లాగిన్ అయిపోలేదు అదే అయిపోతుంది
సార్ కార్లో ఉందా?
లేదు తెచ్చినట్లేదు ఇండిపెండెంట్. Okay, what about 8 milligram aflibercept? Is it available?
No,
Sir,
it's not available in India.
India.
So shortly it will be available. So regarding safety,
In some patients, sir, what I observed is Eylea, whichever we are loading, usually we'll give 0.05 ml. So in patients where sometimes we will be when I have injected more, so what I observed is the duration was increasing, like the gap between the injections the spacing has increased. So yeah, by 8 mg might increase the durability.
so when do you prefer faricimab then? Are you using faricimab?
I used in about 12 patients so far, sir. And of them, 2 patients, there was a good result, but mostly were similar to ranibizumab, mostly other cases.
So still your first line drug is aflibercept only.
Now aflibercept.
So any questions from audience? Anybody? So the audience charts and yeah. So what about incomplete responders? Suppose if aflibercept you have given, patient is not responding well, so then what is your option?
Like which case? I didn't get the.
Any CNVM case, you have given aflibercept, patient is not responding well after 3 loading doses. So do you continue or you switch to some other drug?
I usually switch to another drugs.
So, what about biosimilars? Do you use biosimilars?
I have used in 2 patients, Anira. There is one biosimilar aflibercept. I used and it all. So far, only 2 doses I have given, sir.
What else?
The 2
Which
doses
company?
are
Which company?
Zydus
Oh, they have come with this aflibercept.
aflibercept, but usually I go see only the main thing is finances, sir. When the
Okay.
patient is not affordable,
Hmm.
I give the option of all these drugs, and then based on the patient's choice.
Okay. So
Any others who have given biosimilar, sir? Uh,
the Lupin people are they are coming with biosimilar now. So Zydus, there was some problems it had. So some people are saying some initial reactions are there. So Lupin people are they are coming with biosimilar. So the ranibizumab biosimilars, most frequently people are now using ranibizumab biosimilars. Whatever, if safety issue is a concern, generally we go with aflibercept.
yes, sir.
So because though brolucizumab drying power is more, definitely drying will be better. But because of soft safety issues only, many people we prefer aflibercept. Aflibercept 8 milligrams is also supposed to be very safe when compared to faricimab and other things. So first line drug will be aflibercept unless finances limits the use.
I had given 2 brolucizumab in the last year. I had two patients with vasculitis.
Oh, so
And I published it also, sir,
yeah.
with brolucizumab.
Okay.
But aflibercept, it's always safe. The most
Yeah.
safest drug.
Okay. Okay. So there are not many questions. So Lohit, Lohit. So you're using so many biosimilars of ranibizumab, na?
Yes, sir. Ranibizumab biosimilars.
So then when do you go to aflibercept then?
First, I will see after 3 loading doses. If there is no response for another 2 months, I will see and then I will go for the another molecule, sir. If
So
I'm
your
switching
first
the
line
payment.
drug is if
First
finance
line
permits, you go to aflibercept.
aflibercept, sir.
Otherwise, you go for a biosimilar. If there is
Biosimilar.
no response or under response, you can go to this thing.
Yes, sir. Switch off.
Switch to aflibercept.
Yes, sir.
Sir, in diabetic cases, what is the duration you are saying, sir? Like spacing between the injections with aflibercept?
So three loading doses as usual. Then depends on the response. Generally, we are doing PRN regime only we are
If
following.
the
Because
patient is having any
costly.
nephropathies and all,
Hmm.
usually what I will do is I explain the patient. There is
Yeah, all the other factors, systemic factors, you have to go and control because most of them have very poor control of diabetes. They will have renal problems. They are anemic. So there is a lot of fluid retention actually because of heart failure and all. So all these and lipid profile we have to control. All those systemic factors we have to control. Then only the response will be good. Otherwise, it's a waste of time and injection also. It's a waste of money. So systemic factors should be perfect, which is not there in our people. Most of the people they won't follow regular guidelines and all. So regular they won't go to regular checkup and all. So but still we have to insist them for regular checkup because otherwise it's a waste of money for them itself.
any guidelines for RDS before the injections?
So generally 200 milligrams random sugar we take it as a this thing cutoff. So it should not be random sugar we are taking. So at
Whatever
least
we will feel the discussion between the aflibercept and faricimab, we are just comparing the 2 milligram molecule with 6 milligram molecule.
Yes.
That's what I have to consider. Even with the 2 milligram molecule, low molecular weight compared to the faricimab, which aflibercept has a non-inferior effects over the
okay.
faricimab. And
Actually, the advantage of 8 milligram aflibercept they are telling is you can increase the duration, like
yes,
to 16 weeks you can extend.
Yes, yes.
So that is the main advantage of long acting or high dose aflibercept.
Yes, sir.
So it is coming to the market shortly.
We have to wait another 3 to 4 months, I guess.
3 to 4 months. Okay, good. So, if any questions are there from anybody, audience?
Sir, in the chat box, there are no questions, sir, yet.
Note.
But but to give a clarification about 8mg, we are hearing some good news, sir, and we are like very positive to we are trying to launch by the time of VRSA, sir.
Okay.
If
Very.
everything goes in line.
But cost should be, you should limit your cost. That is the main thing. So Indian population, it's very difficult for the patient to spend 25,000, 24,000 injection. So you have to ask the Bayer people like your management, you have to insist them to reduce it to around 15, below 15,000 would be great. So because biosimilars are coming, there will be competition in the market. So they won't listen to our request. They listen to competition only. Once biosimilar comes, then they will reduce the cost also. So it's the days are not far off. Hmm?
Definitely, I'll pass the feedback to
Please,
company, sir.
whatever.
Hoping for the best, sir.
Because Indian population, it's very difficult to spend so much money for these things.
By the time biosimilars comes, the 8 milligram is available, then it will be a good fight, sir.
Good.
That will be.
The patient support program should be available for that 8 milligram or else.
Of course, they will include it in the
Yes, sir. Actually, I'm coming to that. Company is very positive about and seriously thinking about the patient support program for 8mga, sir. Definitely, I'll come with good news in future, sir.
Okay. Thank you, Srinivas. So thank you, Aditya, Lohit. So thank you very much. I learned so many things from you, and both of your presentations are very good.
Thank you, sir.
So thank you very much. Thank you, Srinivas. Thank you, Bayer.
Thank you, sir. Thank you so much, sir, for your
Bye-bye.
wonderful moderation. Your rich experience really reflects in this conversation, sir. And thank you so much for the two great speakers, Dr. Aditya sir and Dr. Lohit sir, for driving the today's session. And thank you so much for the audience, Dr. Audience, for patiently listening and spent your evening for learning, sir. Thank you so much
Okay.
once again, sir.
Thank you.
Have a great
Bye-bye.
evening ahead, sir.
Bye,
Bye-bye.
Lohit. Bye, Aditya.
Good, sir.
Bye. Right. Bye.
Tech team, you can conclude the meeting. Hi, tech team.
Yes, sir. Can we close the room?
Yeah, you can conclude the meeting.
Yes, sir. Thank you.